Good morning, everyone. My PhD studies are focusing on improving postoperative outcomes after cardiovascular surgery. My name is Nikolett. I'm an anesthetist at the Városmajor Heart and Vascular Center, and my vision is to implement standardized perioperative protocols to improve postoperative outcomes. My mission is for science to prevail over routine. These are my specific goals. My first project focuses on cardiac surgery, and my second project focuses on major vascular surgery. We are conducting a systematic review and meta-analysis to investigate the predictive value of urinary biomarkers in cardiac surgery-related acute kidney injury. Acute kidney injury is a very common complication after cardiac surgery. Its early recognition is essential because we are unable to specifically treat acute kidney injury, so we need to prevent it. We know that we have been using KDIGO criteria for almost a decade now. It is a diagnostic tool for acute kidney injury, but it cannot be used to predict the development of acute kidney injury. Urinary biomarkers are released as a signal of renal stress and early damage. As you can see in this figure, in the bottom part is the rise of creatinine, which happens after the insult within a 48-hour period. But urinary biomarkers have the potential that we can identify high-risk patients much earlier. You can see that they may be identified just after the admission to intensive care unit. These urinary biomarkers have been used and investigated in several critical conditions, but their performance is unclear regarding cardiac surgery. Why is it important to identify these patients between these two time points? If we are able to identify the high-risk patients, then we are able to implement preventive measures in the intensive care unit, and we may be able to prevent the development of AKI. So our hypothesis is that urinary biomarkers can accurately predict the development of AKI, and for that we are conducting a meta-analysis to investigate the predictive value of intra and postoperative urinary biomarkers in the diagnosis of AKI. As I mentioned before, if we are able to detect these patients, then we will be able to prevent the development. We conducted a systematic search with the following search key. We had quite a few articles at the start, and we have 94 eligible full texts. So we are in the process of data extraction at present. My second project is a single-center randomized trial. It focuses on aortic aneurysm repair and perioperative optimal glucose control. As an anesthetist, our aim when we provide anesthesia for a major surgical procedure for a diabetic patient is to maintain normal glycemia, because otherwise we can have quite a few adverse events. We know that perioperative hyperglycemia is associated with adverse postoperative outcomes, and to prevent the hyperglycemia during the intraoperative period and the early postoperative period, we use intravenous insulin. Intravenous insulin administration carries the risk of hypoglycemia, which can be detrimental for patients undergoing a major vascular surgery. Currently, newer antidiabetic drugs have been investigated, like glucagon-like peptide receptor agonists. There is a typo there, sorry. So these are agonist drugs. One of them is liraglutide. They have the advantage that they improve glycemic control without the risk of hypoglycemia. There are no significant data regarding their perioperative use, and that's why our aim is to investigate the intraoperative glucose control with preoperatively given liraglutide injection in patients undergoing open aortic aneurysm repair. So we are planning a randomized trial where the intervention will be preoperatively given liraglutide and obviously plus minus insulin to maintain the proper glycemic control. And the comparator will be the placebo plus minus in insulin infusion. We would like to investigate the glucose control intraoperatively and the early postoperative period, and also the insulin requirement. And as secondary outcomes, we would like to examine postoperative complication rates. And our hypothesis is that the liraglutide is superior to placebo in open aortic aneurysm repair for glucose control. Its clinical implication is that the euglycemia reduces postoperative complications. We would like to include adult patients who undergo elective open aortic aneurysm repair and have type 2 diabetes. In our center, approximately 80 patients undergo elective open aortic aneurysm repair per year. So we think that it might be feasible. We are planning these two arms, liraglutide versus placebo. The outcomes are glucose levels, insulin requirement, and the postoperative complication rate. So these are my two running projects to improve postoperative outcomes with intra or preoperative measures. Thank you for your attention.
Thank you very much for this nice presentation. My question would be regarding the second topic. What do you think? Does it make a difference whether the patients involved in the study had their diabetes well under control or whether they were non-compliance patients at the time of admission with a hemoglobin A1C level above 10, for example? Does it make a difference?
Thank you for your question. Yes, it does make a difference. There are two studies who investigated the perioperative liraglutide, and they've excluded patients who are not well controlled for diabetes, and they've also excluded patients who have extremely high insulin requirement for their type 2 diabetes. So these patients must be well under control.
Congratulations, Nikki. My question is about, is there any specific cause why did you choose aorta aneurysm instead of other surgical processes like bypass or valve replacement?
The main issue is that cardiac surgical patients have already been investigated. So that study has already been done. It's a quite good quality study, so I don't want to repeat that. And for other patients who are encountered, open aortic aneurysm repair is a significant surgery. It has a high impact on the glucose levels of patients, and also it's a massive surgical stress. So we can, I think we can really make a difference if we avoid hyperglycemia in these cases and hypoglycemia as well.
So I have a question, Nikki. What would you consider a better primary outcome? Is the blood sugar level? We've been discussing that, but we haven't actually answered that question.
Yes.
And taking it as a continuous variable, or patients with hyper, or the number of patients with hyper or hypoglycemia, so taking it as a dichotomous variable. What is your gut feeling? Which would reflect the difference between the treatment and the control arm better?
Thank you. I think if we dichotomize this outcome, then we will lose important information, but it may have a large effect, so it would be a significant outcome. So probably we could rather determine as an effect measure the time spent in normal glycemia, and then these are comparable. I mean the control arm and the intervention arm, and also it can be significant as well.